Bismillahirrahmanirrahim. Cardiac MRI imaging application in 2019. Cardiovascular diseases are the leading cause of death worldwide due to the high incidence of cardiac, coronary, and aortic diseases. While cardiac MRI is not the first modality routinely used in the evaluation of patients with ischemic heart disease, it has produced significant advances in understanding circulatory function and acts as a powerful biomarker for intervention studies. Advantages of cardiac MRI include multi-planar capability, and MRI contrast may have low risk for allergy or contrast-induced nephropathy. It's a non-invasive radiation-free modality that produces a high-resolution and 3D images, less operator-dependent, and offer anatomic and functional diagnosis. Equipment for cardiac MRI: 1.5 Tesla magnet with a strong fast gradient using a dedicated cardiac coil should be used with ECG gating to reduce the motion artifacts. Due to the position of the heart within the chest, in addition to the true planar axial sagittal and coronal planes, multiple oblique planes should be used to better clarify the cardiac chamber and the great vessels. This is normal axial view, short axis view of the right ventricle and the left ventricle, two chamber or vertical long axis view demonstrating the left atrium and left ventricle, horizontal long axis view or four chamber view resulting right atrium, left right ventricle, and left ventricle. Three chamber view for the left ventricular outflow tract in addition to the left atrium and left ventricle. Aortic view or candy-cane view shows the aorta along its entire thoracic course with some of its branches. Also, coronary arteries can be interpreted with high resolution using proper gating. Clearly demonstrates the RCA, the left coronary artery bifurcating into LCX and LAD. This shows the left ventricular vascular territories supplied, where the red color refers to the area supplied by LAD, the green for the area supplied by the RCA, and the blue for the area supplied by LCX. Multiple blood sequences are used, but mainly depends on the black blood sequence with a spin echo sequence or bright blood sequence with the gradient echo sequences. Inversion recovery is used, especially with late gadolinium enhancement, and unused PCR is used for phase-sensitive inversion recovery. This figure shows the first spin echo sequence where the blood appears black. It's good for anatomic delineation. The second photo for white blood sequence or bright blood sequences is a called for functional assessment. The third for the steady state free perception with clear out delineation between the black pool and the myocardium. It's also the horse for functional imaging. The fourth image is a phase-sensitive inversion recovery used for late gadolinium enhancement. Cine Imaging is a short movie that shows the heart motion throughout the cardiac cycle and used to assess the myocardial motion abnormality. Phase contrast image or velocity encoded images allow quantitative measurement of the flow. Myocardial tagging, where low signal intensity grids are superimposed on the myocardium at the beginning of the cine sequence, and subsequent deformation of these lines throughout the cardiac cycle is noted. Color maps also allow circumferential strain abnormalities, quantify the magnitude and extent of this contraction abnormality. احنا كده تمام. لا عادي مش اكتر من ان صوتي راح. First pass perfusion. As perfusion imaging detects downstream of blood flow within the myocardium, cardiac MRI can distinguish subendocardial from subepicardial from transpleural perfusion even better than SPECT2. Late gadolinium enhancement after 10 to 15 minutes with intravenous gadolinium is the most extensive validated technique for the detection and quantification of the myocardial infarction. It's a different type of late gadolinium enhancement. First image subendocardial enhancement, the second mid-wall enhancement, third transmural, and the fourth image patchy enhancement. Indication of cardiac MRI include ischemic heart disease. It assesses myocardial availability as well as myocardial perfusion, bypass graft patency, global and regional ventricular function. It also quantifies the ventricular mass and volume, and systolic volume, and diastolic volume, stroke volume, and ejection fraction. Second, for cardiomyopathies, for valvular heart disease, congenital heart disease, pericardial diseases, and cardiac masses as well as the aortic diseases. In myocardial infarction, first pass imaging, the myocardial infarction appear as a hypoenhanced area that appear as that gadolinium enhancement with intensity enhancement. It also allows differentiation between ischemia and infarction, where the ischemic enzyme is a salvageable area which will benefit from revascularization procedure, while the myocardial infarction wouldn't benefit. So in this stress testing using dobutamine or adenosine stress, the first with stress image, the ischemic area appear as a hypoenhanced area that doesn't appear at the wrist image and doesn't have contrast enhancement, athlete gadolinium enhancement, in contrast to this segment of myocardial infarction that appear hypointense during stress and during rest, as well as late gadolinium enhancement. It also allows differentiation between the acute and the chronic myocardial infarction, while the acute infarction saw edema as the T2 sequences and late gadolinium enhancement. In severe acute myocardial infarction, subendocardial plaque or signal void appears surrounded by enhancing subendocardial region with microvascular occlusion due to necrosis of the blood vessel as well as a myocyte that indicate a poor prognosis. Different types of cardiomyopathy also can be assessed using cardiac MRI. It's able to characterize cardiomyopathies by their morphologic and functional phenotype as well as by tissue characterization. In this case, hypertrophic cardiomyopathy, the left ventricular hypertrophy, where the wall thickness exceeds 12 to 15 millimeter during diastole, with patchy or ventricular lead gadolinium enhancement. These three different types of hypertrophic cardiomyopathy, either diffuse concentric hypertrophy of the left ventricle, or focal or mesh-like. Sometimes the papillary muscle only hypertrophied, exerting mid-ventricular obstruction, or the special type is speed that's constructed to the apical. In dilated cardiomyopathy, which is the most common primary cardiomyopathy, we notice dilated cardiac chamber. Dilated cardiac chamber is seen, and impaired wall thickening is noted during Cine Imaging. Athlete gadolinium enhancement involve subepicardial or mid-wall myocardium. This is a special type from dilated cardiomyopathy called Takotsubo cardiomyopathy or apical ballooning syndrome. Arrhythmogenic right ventricular cardiomyopathy is a rare type. It's characterized by severe global or regional right ventricular dilatation up to aneurysmal formation with due to fatty or fibrofatty infiltration of the right ventricular myocardium. At T1 image, the fatty infiltration appears with bright signal, and here is the aneurysmal dilatation of the right ventricular wall. Here shows the enhancement of the right ventricle denoting fibrotic infiltration. And restrictive cardiomyopathy due to multiple infiltrative diseases like amyloidosis and sarcoidosis and Leffler's. This is against normal left ventricular function and systolic function. However, diastolic dysfunction leads to congestive heart failure leading to dilated post atrium. In this patient with amyloidosis, circumferential hypertrophy is noted through the left ventricular wall with subendocardial and mesocardial extension of the lead gadolinium enhancement. Left ventricular non-compaction is hypertrophy ventricular trabeculation surrounded by an outer compacted epicardium. The increased thickness of the non-compacted layer ratio to the compacted layer exceeding 2.3. At axial image, at short axial image should demonstrate more than 4 trabeculation in the cut. Please show the trabeculation of the left ventricle resembling the right ventricular trabeculation with increased non-trabeculated to trabeculated layer. Recent advances in functional cardiac MRI include parametric mapping. Parametric mapping can perform the tissue characterization without the need for contrast agent. It depends on the intrinsic magnetic T1, T2, and T2 star criteria and relaxation properties of the myocardium. We can calculate the extracellular volumes that increase in cases like myocardial infarction or cardiomyopathy and estimate the extent of myocardial pathology. First, two images from T1 mapping. In a case of anteroseptal myocardial infarction, this is a fibrotic infarcted segment. This is a diffuse fibrosis involving the myocardium. In a case of cardiomyopathy, this 2-2 parametric mapping of a normal patient compared to a patient with diffuse edema in sharp stress syndrome. Diffusion tractography, it consists of imaging the direction of the myofiber to evaluate the microstructural organization of the healthy and infarcted myocardium. It's performed at 1,000 to 2,000 seconds per minute p-value with mean diffusivity equal 0.89. This figure shows the normal diffusion tractography, which is smooth and constant at normal human heart. This is in a normal rat, and this is in a rat with induced ischemia, where destruction of the myofibril is clearly indicated, forming a mesh-like abnormality. Metabolic imaging, also applied by MRI, MR spectroscopy, allowed determination of the alternation in the metabolism, which are a common feature of many cardiovascular diseases, either acute or chronic. H1 and phosphorus 31 or hyperpolarized carbon-13 pyruvate can detect the cardiac metabolite. And this figure shows the interventricular septum show the high triglyceride content. 18 floor FDG PET MRI allow assessment of the anatomical, functional, oxygen consumption and perfusion and metabolic activity of the myocardium, all in a single acquisition. 4D flow MRA velocity mapping or flow sensitive 4D MRI, it's a time resolved 3-directional and 3D phase contrast MRI. It assesses the pulmonary and the aortic lesion as well, flow parameters as well as the wall parameter with high spatial resolution. The first show the 4D MRI flow in the aorta at the early, mid, and late systole, supports the image in case of aortic aneurysm. Wall parameters also can be assessed using MRI for calculating the wall shear stress to measure the drag force of the blood on the arterial wall. With abnormal high wall shear stress indicates a region at risk for formation of aortic aneurysm associated with altered flow direction and velocities. Lastly, the pulse wave velocity or MR elastography that measures the wall stiffness and offers 3D full coverage of propagation of flow waveform along the vessels. Thank you.